there is nothing really great and new about this topic, except for the fact that you have to do a 01 course and we have to teach. So what I'll do is, amongst the speakers who are around, okay, so what I'll do is I'll randomly ask some of you to give some comments based on my slides, right? And then we can probably have a discussion towards the end. Okay, so have a look at this prescription. So we start with Dr. Abhay on the screen.
Yes, sir.
Yeah. Yeah, can you give your comment about this prescription?
Yes, sir. Here, we have the patient's name.
Yeah, excellent.
And then the handwriting is not in capital letters.
Yeah,
And
okay.
the dose is not clear.
Yeah,
And the duration is also not written clear.
yes. The
And
diagnosis is noted.
yes, sir, the diagnosis is not written. And signature is also not clear. And
Yes,
the designation of the person who has written is also not clear.
absolutely. So how would you rate this? Out of 10, how many points would you like to give?
-1, sir.
-1. That's very good. Okay. Dr. Ankita Singh, what about this? Dr. Ankita Singh around? Okay. If anybody, yeah. Oh, ma'am, you're working. What is your comment about this? Audible? I think you'll need to unmute yourself.
Yeah, yes, sir.
Yeah. What do you think about this prescription?
Sir, it was written very widely, difficult to understand what is written actually.
Okay. And what about the areas that are circled?
Uh, the areas which are circled. Uh,
Maybe I think in the background somebody can. Acha,
circle
okay.
is
Okay. Okay, Ankita, mute yourself, please. Just mute yourself.
okay.
Okay. I will pass on to Ankit. Ankit is around? Dr. Ankit.
Yes,
Yeah.
sir.
What's your comment on the areas I have circled?
Sir, it's injection regular insulin subcutaneous. Short form should not be used.
Yeah.
BBL or BD.
Yeah.
You
So
would know.
BF means before breakfast?
Yes, sir.
BF means before lunch?
And it should be specified how much time before lunch or before meal.
Yeah. And what does BD mean?
Sir, before dinner. And
Yeah,
BD
but I can misinterpret that for twice a day also, no?
for twice a day also. Yes, sir.
So that means the abbreviations are giving you an issue. And if you look on the other side, it says injection insugen. Is that insugen?
Regular or
Regular. 100.
4-hourly subcutaneous. That's sir. What does it mean? I can't interpret.
Yeah, okay. 4-hourly subcutaneous and stat. Okay, so there are inherent difficulties in this prescription. What about this? Let's say who? Dr. Ayushi, if you are around. Okay, maybe somebody else. Dr. Chandan. One second. Hello. Yes, ma'am. Ma'am, I have already started, ma'am. Yes, ma'am, I've started. Okay. No one was around, so I thought I had to start, so I started. Okay, okay. Okay, 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 ma'am. I'll continue, or should I wait for you, ma'am? Okay, okay. Right, madam. Okay. Anybody else? Dr. Navya? No?
Yes, sir.
What do you think is
Yes.
wrong with this prescription?
There is no date, and what is written, it's not even
It's
legible.
not
It's
legible.
a
See,
tablet
yeah.
or injection or what it is. We
So
can't
how much you would rate this out of 10?
Zero.
0. Good. Okay, now this is a standard SGPGI prescription that you and I are all used to. And there are two types, one is small and one is big, and I've chosen the longer one. Now I'll show you some prescriptions from SGPGI. Dr. Nayab Danish, what would you rate this prescription as? Nayab Danish. Okay. Dr. Neha? Okay. Dr. Nishant? Yeah.
Yes, sir. So very
Yeah.
poor.
This is poor. I thought this is nice. It
The
says
brand,
brand
brand
names and mentioned. So this
has
particular
mentioned.
doctor wants only this brand. So is that wrong?
Yes, sir.
Is that wrong or is that okay? Don't you want a particular
Wrong.
brand? Maybe
This
you're
is wrong,
failing
sir.
that brand. Okay. I thought that's okay because you might have a particular preference to particular brands, but the handwriting is okay, the legibility.
Yeah, it's
Okay.
fine, sir. Let it.
But it does not say, if you look at it closely, it does not say when to give, no? And like syrup, no worm, it doesn't say when to give, how many times to give, right?
Yes, sir.
Okay, what about this one? Dr. Radha, what is the problem with this?
Yes, sir. It's written as BD and OD, which is not really, the patients don't understand BD and OD.
Right,
This
you're
is
right.
terminology that medical people use.
Yes, exactly. And another thing is that they have not given how long to give. No, tablets Felcal 500, one BD, how long we don't know. How much would you rate this prescription as?
One, sir.
1. You're a strict examiner. Okay. What about the next one? Dr. Rajat. Dr. Rajat.
Yes, sir.
Okay. Dr. Rajat, what do you think about this prescription?
Sir, this is fairly fine prescription.
Yes.
Proper dosage and
Okay.
that
Proper dosage.
duration is also mentioned.
Yeah. So this is a
Writing is also
typically
fine.
good prescription. How much would you rate this prescription as?
Sir, if sign is there, I'll rate it maybe 8. If sign is not there, then 6.
Very
Because
good.
I cannot see the sign of the doctor
Very
here.
good. But look closely on the top. The person's name has been changed to something else. Have you seen? So
Sir,
that
actually
means,
that side is folded.
sorry, that I'm sorry,
The end folded where the name is written.
and it folded. Actually, it has been striked off and written somebody else's name. So this is a typical prescription where you are writing it for somebody, but you end up writing it for somebody else, and then you realize the mistake and write it again. Okay, so there is potential danger with such prescriptions. What about this one, Dr. Shruti? Dr. Shruti? No? Dr. Vrinda?
Shruti here.
Shruti and Vrinda both, yeah, no problem.
So too much information has been scrambled into the prescription and they've written between the lines and added tablets, so it's not very clear.
Not clear. So it's very, very compact and the writing is not clear, except for the fact that this person has written in block letters, and block letter writing is a good thing because it gives clarity. Okay, what about this one, Shivang?
Yes, sir.
Dr. Shivang, do
sir.
you like this prescription?
Uh, Sir, the writing is not clear. The doses are not mentioned.
Yes. So this is highly poor prescription. Okay. Maybe who else is there? Let's see. Dr. Bella, what about this prescription?
Sir, but signature further in the end,
Okay, and
age of the is not
anything else?
mentioned.
Okay, and date is not mentioned.
Date.
So by the way, this is my prescription, okay? So I've purposely left it that way. Okay. Now, we look at how prescriptions are going wrong, and this is a small study we have. So it's not a study, but it was a review article that somebody had written. The medication errors that go on in our community. And they say that 1 of 8 people dying in United States is possibly because of medication errors. In UK, the prescription errors are up to 16%. In India, it is up to 15 to 25%. Okay, right. What is a drug prescription? It's a written order. It is a list of medications. It's an instruction for consumption. There's a finite period, so you don't write indefinite prescriptions by a licensed individual, maybe a doctor or a nurse practitioner in the West. And the goal is patient care. So the characteristics of a prescription should be, it should be legible, it should be appropriate, it should be comprehensible, it should be renewable, or it may have an endpoint like an infectious disease. And it should be a licensed individual who is responsible, and ultimately it should be beneficial to the patient. Now, I'm not going to teach you how to write a prescription, but discuss the difficulties of a poor prescription. When you write a prescription and it's a written order, first of all, it's a documented order, right? So that has its own legalities, good and bad. For the patient, it is a matter of reference. It is a reckoner, ready reckoner, and a reminder that he's supposed to take it before breakfast or after lunch or things like that. And for the doctor also, it's a matter of comparison. What prescription did he come with? What are we writing? Or between 2 visits, what is the difference in the prescription that we have written? When we write list of medications, we usually have a baseline diagnosis, which is provisional or definite, a tailored for each patient in terms of his age, comorbidity, and other factors. So, somebody with a diabetes mellitus may have a different prescription, and somebody, a pediatric patient, may have a different prescription. Main medications, that means monotherapy or polytherapy. For example, a seizure disorder may be controlled with one drug or maybe multiple drugs. Ancillary medications it may have, which may not actually cure the patient or help the patient, but it may be supportive, like hematinics, calcium, things like that. And there is addition, deletion, and modification in each visit. Now, when you give instructions for consumption, you have to mention the dosage, which is pertinent to the age, the pregnancy, comorbidities, and so many other factors. The schedule, which is OD, BD, twice a day, thrice a day. But when we write abbreviations, we have to be very, very careful. The regularity, that means are you going to give it as a stat dose, a single dose, SOS, or scheduled? Timing, which is fasting, postprandial, drug interactions. The duration, how long you want to give, and the route of administration. Prescriptions need to be for a finite period. By finite period, we mean that it has to be given for particular 2 months, 3 months, 1 month, 1 week, things like that, so that you have a chance of renewing it. It's like a contract. So in chronic diseases, you would like to renew the prescriptions based on the natural history of the chronic disease. And or you might have an endpoint which is an acute event, like it's a febrile illness, or it's an infectious disease like typhoid, malaria, things like that, you get a chance to review the case each time the patient comes to you, and you also get a chance to review the efficacy of the drug. There are some times when you write indefinite periods, there might be an over medication risk. There are also financial implications. That means if you write a drug which is very expensive for about 6 months to a patient, he might not have that kind of finance at that point of time to buy. It is also dependent on the availability in the local area and the geographical implications. So your patient is coming all the way from Chhattisgarh or a very remote area where there is inaccessibility to health, then you may write a big prescription for a longer period. And secondly, you have to look at the availability. That means, is the patient going to buy from a city? Is it available in his town? Do you think it's going to be available in his city or town? So for example, I am a pediatric gastroenterologist. I look at Wilson's disease. D-penicillamine is a chelation that is not widely available everywhere. So our patients have to be told that you go home with 3 months of drugs, and as you are finishing off your medications, that means 15 days before you finish off the medication, come to a big city, buy the drug, and go back. So the availability and geographical implications make a lot of difference. It is also important to know that the pharmacies will not stock a lot of drugs which are very special drugs. For example, I just told you about chelation, D-penicillamine. The pharmacy will not store 1,000 capsules of D-penicillamine. It may store about 200 to 300. So depending on what drug you're prescribing, you might want to, have an idea whether your pharmacy is going to stock or not. So if the patient is going to buy from a in-hospital pharmacy and an outside pharmacy, the stock availability might be different. It has to be by a licensed individual. By licensed individual, we mean either the drug is very special or the doctor is very special. Now, there are some professions where prescription is not required at all. For example, if you are a pathologist or a microbiologist, you don't need to write. But a physician, a surgeon needs to write, so you have to be very careful. Some specialists may order special drugs, like for example, a urologist can only prescribe sildenafil. But for example, if you take any other profession, maybe a gastroenterologist might not require to prescribe sildenafil. Food formulations, we as pediatricians, we have very specific food formulations. Only pediatricians and very special gastroenterologists can order these. Others cannot. There are special drugs, for example, morphines and sedatives. So those of you who are in anesthesia or other allied fields will know the fact that morphines and sedatives can only be prescribed by or with a MCI registration number. This is to prevent abuse and restrict the use. We should always try and see that it's not over the counter. And now with all this mixopathy that is going on, that is allopathy and non-allopathy, you must be hearing a lot about that in the news. This problem of licensed individual has become a very major issue. And with this mixopathy, when the patient comes to you, you tend to doubt the authenticity of the prescription. How is it important to patient care? It gives benefit to the patient by alleviating the symptoms, controlling the symptoms like oral hypoglycemics, reducing the tumor load like chemotherapy, curing the patient like antibiotics, prevention of a complication like anticoagulation, and palliation. Ultimately, what you want is to give lifespan and comfort to the patient. Now, how does a prescription communicate to the patient? When you give a prescription, it shows the doctor's intention to care. It demonstrates the responsibility of the doctor. It sets rules that the patient must abide by. If you give a very elaborate instruction, it becomes patient friendly. Supposing you're giving a instruction for a bowel wash with polyethylene glycol. So if you give elaborate instructions, the patient is not confused and it becomes patient friendly. And once completed, he has completed that set of drugs which you have prescribed for a finite period, the patient should come back for review. So by communication, we mean what it means to the doctor, what it means to the patient. Now, legibility has become a very major problem, and we sympathize. As a doctor, I can understand that we are always on the go. We don't have time to eat, we don't have time to sleep, but we must write the perfect prescriptions. It's a very big challenge. Practice is very busy. Those of us who, those of you who will go back and practice, have private practices, you know, the busier your practice becomes, that means you are becoming more famous and prospering. But a busy practice, that means you're going to have an overloaded OPD. So service is going to get compromised. And those of us who are writing the same kind of prescriptions every day, maybe for cough, cold, fever, you know, you write like pediatricians, we have majority of pediatric practice in the community is cough, cold, fever. So the pediatrician, for him, it's a mundane prescription. You know, he just goes on scratching the same thing for the next 5 set of patients. With our increasing age, our writing of prescription becomes even worse. Handwriting becomes worse, patience becomes less. And always remember, the prescription, you are not writing for yourself. You are actually writing for someone else who you don't know. So there will be a tendency not to write it well. You compare yourself when you're writing, filling up a form for your Aadhaar card or your passport, how legible you are. Every letter you will write properly because it means to yourself. But since this patient does not belong to you personally, you're not writing it for yourself, you're writing it for somebody else. So legibility will always be an issue. Now I'll give you some facts. This is a survey done in a district hospital in Ahmedabad. And in this, they have looked at the commonest drugs that are involved in medical error. And they have seen, like I've shown you in the previous slides, they have seen that antibacterial drugs and the drugs used in gastrointestinal diseases are most often having medical errors, both in the medical ward as well as the pediatric ward. And if you see the types of medical errors, right? You see the types of medical errors, you will see that the most important medical error is the prescription error, which is an inappropriate selection of medicine, or because the medical history of the patient has been incomplete. But mostly it is because of inappropriate selection of medicine. There are also administration errors, but we will not go into that. If you look at the types of error that has happened, then most of the errors have occurred with IV fluids, because this was a district hospital. It was a inpatient unit. So they've seen that the IV fluids and the antibiotics are mostly the ones that have gone wrong. How has it adversely affected patients? Serious and life-threatening drug interactions have occurred in at least 1/10 of the patient with potential threat and clinically observed 2. That means 1 out of every 10 patients that they have prescribed, and this is a district hospital we are talking about, has undergone a grave issue with the prescriptions. When we have to evaluate prescriptions, there is, I didn't know, and actually this is the first time I also came across while taking this, while writing up for this lecture of yours, that there is something known as a FUD case criteria. It's a 30-point scale, and it tells you what is the rationality, whether it is rational, semi-rational, or irrational. Points are given. There are various segments, and I'll show you in the next slide. You don't need to learn all this, but points are given and they are rated. And finally, what happens is they decide whether it was an irrational drug, whether it's an unnecessary drug or injection, if it's a hazardous drug, or an unnecessary injection, right? So this is the FUDK scoring system, which has looked at 4 main categories: the correctness of the main drug, the dose, the duration, frequency. Then the third point is correctness of the complementary drug, and the dose, duration, and frequency. And based on these two, they make up and see whether the prescription is correctly written or not. Now, based on this district hospital in Ahmedabad, they had finally analyzed and seen that about 30% of their prescriptions were irrational, and a majority of their prescriptions were semi-rational. So that means for every patient, if you start writing hematinics, it becomes an irrational practice, right? And 1 out of 100 patients, if you write unnecessary hematinics and placebos, it may have drug interactions with other main disorders. Why do we go wrong? We go wrong because of workload or fatigue. Now here I'd like to tell you a little story. When I was doing my MD residency and I was in first year, and it was a heavy duty night, and in the morning I was posted to go to I think it was an immunization center, Nanganwadi. So the bus leaves at 7 and I have to quickly wrap up my ICU and go to the catch the bus. And there is a patient who's been admitted overnight with refractory seizures. We've not been able to maintain the patient on standard antiepileptics like phenytoin, phenobarbital, and all that. And my consultant says that you should load this patient with IV valproate. Now, what happens is, in a patient who has come into the ICU, there is a huge list of medications. There is no space to write. So I wrote the medication on the other side of the prescription of the drug order and told the sister, kindly load, I'm leaving for immunization. Now what happens is the duty changes at 7 o'clock. If I'm leaving, the duty changes by 8 o'clock. So the new sister does not hand over, the old sister doesn't hand over to the new sister, and the page is not turned, the overleaf is not seen, valproate is not given, patient dies. Ultimately, what happens is, when I come back after my immunization program and come and see the patient is already dead and the entire unit is boiling in anger, because the reason why the mistake has happened from the sister's side is because it is written on the overleaf. Now, that is not something I had anticipated, but that is something that has happened. So I, in my justice, have written it, but the sister has not read it. And why this all happens is because we are overloaded with work. So if you have 10 patients in the ICU, mistakes will happen in 1 or 2. So workload, work overload, fatigue becomes a major issue. Sometimes we forget to transfer, the major drug from one page to another. So I remember another time where in a nephrotic syndrome, I had forgotten to write steroids for the next 3 days because I had missed the steroids in one page and I had forgotten to write in the next few pages, till I realized that it has not been given. So these things go wrong, and in residency, we understand it's the worst during residency. The workplace can be very noisy. There are a lot of interruptions. Lighting may be an issue. So sometimes when I'm sitting in the OPD, you get a call, oh, you are quickly asked to come for a meeting. There is so much noise, so many children crying that you can't focus on your on your prescription. Polypharmacy. Sometimes too many drugs make it very congested. You don't know what you're writing. You may want to write, a Shellcal 500 mg BD, but instead you write 100 mg BD. So things go wrong because there's a huge list of medication. Right? Confusing nomenclature of drugs. There are times where, for example, there are some drugs where the primary drug, the pharmacological name is something, and they dispense you. For example, Cipzox, if you have heard, SCIPZOX. Cipzox is a drug that contains a centrally acting muscular agent, and it contains diclofenac and one more thing. I can't remember exactly what. Now, if you write Cipzox, somebody might give you Ciplox. So Ciplox is ciprofloxacin. So there may be a confusing nomenclature of the same. Complicating illness. Sometimes patients have one illness leads to another, and the number of drugs start increasing. So we get confused there. Increasing medications. The size of the prescription forms becomes very important. As I have showed you in my previous slide, in our SGPJ, we have two types of prescription, the shorter ones and the longer ones. Imagine fitting 10 drugs in the short prescription because of its availability. So if that's the only thing that is available, you are going to compromise. So people are not going to be able to read. Complicated calculations. Infusions. For example, you want to start a midazolam infusion, or you want to start any other infusion. The rate at which you want to give, the amount of drug you want to dilute, may all become a very complicated mathematics. In pediatric cases, we have a lot of difficulty, and because we have to base it based on the kilograms of the patient, the weight of the patient, or the body surface area. And the last issue why we go wrong is lack of standard operative guidelines. One second, I have something is frozen here. Okay, how to minimize these errors? Now, okay, so where do patients go wrong? Sorry, where do patients go wrong? Patients go wrong. Literacy is a major issue in our country. Intellect is a major problem. It is another problem in our country. What you say, what they understand, there is a difference in understanding and conveying, and it all leads to literacy, intellect, and possibly dialect and language issues. Okay, poor understanding or over understanding. Over understanding becomes a major issue. Many times patients understand more than necessary, and they are not concentrating on what you are telling them. Rarely they are overzealous. So we have a lot of patients who take drugs unnecessarily because they think by adding 2 or 3 more drugs they will be in a better shape. So they might be overzealous. They might be skeptical. The other end of the spectrum is skeptical, where a patient does not really trust the antibiotic you're giving. So if you've written amoxiclav 625 mg twice a day, they may think, oh, that's going to harm me. I'll just take one drug, and not for 5 days, but for 3 days. So being skeptical and compliance issues make it very complicated. Supervision. Sometimes patients are not supervised, especially children and old age patients. So what drug they are taking may be a major issue. Comorbidity. So if there's a debilitated patient who cannot get up from the bed, for that patient to take the medication becomes a major problem. Polypharmacy and doctor shopping. Once again, patients may have a tendency to go from one doctor to another, merge the prescription, and then that is where things go wrong. How to minimize errors? This is an age where everything is becoming electronic, so electronic prescriptions are possibly the best. So when you raise forms in the ward, you have an electronic prescription that is given, and it is easier to give. You must write with block letters. It's favorable to write with block letters. I can't say must, but it's favorable to write in block letters. Try and use pharmacological names wherever possible and in special cases. But you may have a choice of a certain brand, which you are, like, for example, I showed you a sample prescription where that particular doctor only wants that particular brand. Maybe he or she has faith in that. But try and use pharmacological names wherever possible. Avoid abbreviations. OD, BD, TDS, PRN doesn't mean anything. Instead, use symbols, okay? So if you use 101 or if you draw the tablets, as circles, then the patient understands better. Depending on where you're practicing, a local language translation would be very, very useful. So if the patient is from a Hindi belt or a belt in southern parts of India or eastern or western, they might not understand the prescription in English language. Telepharmacy. Telepharmacy. Now, telepharmacy has is a new upcoming thought process, and telepharmacy is these days that is the most upcoming thing, and it's like Amazon or Alexa or Siri. You just say, Alexa, write me these following drugs, and it gives you those drugs in a sheet of paper, prints it out, and gives it to you. So it eases your practice. Manpower increase. You must increase the manpower for all this. You need technical staff and typists to help you out, especially if you're writing electronic prescriptions. And it's very important to audit yourself once in a while and see, are things going right? Are things going in the wrong direction? And where you can bridge the gap. Now, this is a small verbal feedback from the GH staff pharmacy. I went yesterday and asked them what they face, because this is a staff pharmacy, so we are very careful. 10% still have very poor legibility. So what we write, they can't read. 15 to 20% have wrong dosage, wrong timings. And 20 to 30% have unavailable brands, and no other option is suggested by us. So they are dealing with all this, but in very rare cases, that is 1 to 2%, they are sending it back to the doctors for corrections. So this is in SGPGI, which is a tertiary care hospital, a very sophisticated hospital. Imagine if this is the rate here, what would be the rates in other district hospitals and smaller places? So prescription writing is a very important part of our practice. And we have to be careful wherever possible, because it communicates with the patient.